My special appreciation goes to Dr. Malay Sharma for this kind of invitation. The topic assigned to me is Therapeutic EUS in the year 2021. EUS was introduced as a new imaging modality about 4 decades ago. Although it was a crude imaging modality initially, it made a great stride to accurate diagnosis. Nowadays, we can use not only EUS FNAB, but also elastography, contrast-enhanced EUS, and fine flow image for accurate diagnosis. It is also used actively for the minimally invasive therapy of pancreatobiliary disease. These are areas of therapeutic EUS in the year 2021. Pseudocyst drainage, biliary drainage, pancreatic drainage, gastrojejunostomy, EUS CPN or CGM for pain control, interstitial brachytherapy, vascular therapy, gene therapy, and tumor ablation. Among these, several areas are already covered by other doctors, and the time is limited. So today, I will be just focusing on tumor ablation. There are various types of tumors in the pancreas: neuroendocrine tumor, mucinous cystic neoplasm, and pancreatic cancer. How are we treating these cases? Current principle is, if the lesion is purely benign, regular follow-up is recommended. If it is malignant or potentially malignant lesion, surgical resection is generally recommended. However, surgical resection carries significant morbidity, even mortality, and long-term functional disability is the major issue. This is 99-year-old patient with recurrent attacks of hypoglycemia. The CT scan did not show any lesion in the pancreas. So we did EUS examination to find out the lesion in the pancreas. When we did EUS, there was about 1 cm sized hypoechoing nodule in the head of the pancreas. When we added contrast-enhanced EUS, this is a B mode image. This is contrast-enhanced harmonic imaging mode. This is the time after contrast injection. After about 10 seconds after, during arterial phase, the lesion shows strong arterial enhancement. This is the typical finding of NET, including insulinoma. So based on clinical history, biochemical data, and EUS finding, and the contrast-enhanced EUS findings, we thought this lesion was the culprit lesion causing hypoglycemia. But the problem was how we treat this case. This is almost 100-year-old patient. Operation of pancreas head was risky, and chemotherapy may not be a good idea. Observation was not possible due to recurrent collapse of the patient. So we decided to do EUS-guided ethanol ablation. To ablate the lesion, 22-gauge FNA needle was used, and the bottom half was already treated. Now we are targeting upper half of the lesion. After insertion of the needle to the upper hypoechoic area, we injected 0.2 to 0.4 cc ethanol into several areas. Three days after therapy, we repeated contrast-enhanced EUS. This is before therapy, this is after therapy. If we focus on this red arrow area, there was strong arterial enhancement before treatment. But after therapy, same area showed no contrast enhancement at all. So we assumed that this lesion was effectively controlled and the patient was discharged. The patient never had hypoglycemic attack thereafter. This is one example of EUS-guided tumor therapy. EUS-guided tumor therapy is actively investigated by several methods: ablation therapy using ethanol, RFA, laser, or PDT. Intratumoral injection of gene or immunoagent or chemoagent has been tried for a long period of time, showing variable results. Among these, what I think will be useful in the near future are ethanol injection for solid tumor, like previous case, or EUS-guided RFA for solid or cystic tumor, and ethanol injection for cystic tumors. So I would like to touch each method briefly. Firstly, ethanol injection for solid tumor. Ideal indication of ethanol injection are small benign tumors such as insulinoma, neuroendocrine tumor, or solid pseudopapillary neoplasm. If you see this review article, we can realize that this technique is investigated by several study groups showing effectiveness and safety. But there are still issues on this technique. The method of injection is not standardized yet. The amount of ethanol is not calculated scientifically. It is empirical treatment. Remnant viable tumor is another issue when we target the larger tumor. Let me move on EUS-guided RFA. This MEN type 1 case, and the patient already received multiple operations. Now we can see another NET in the resection margin of the pancreas. The patient refused any more surgery. So we decided to ablate this lesion by EUS-guided RFA. 19-gauge RFA electrode was inserted deeply in the right side of the screen and started ablation using 50 watts and 10-second ablation for one spot. After one spot ablation, we retracted the needle into the superficial part of the lesion and repeated ablation. This is one line ablation. After one line ablation, we removed the electrode and punctured to the left side of the screen and repeated another line of ablation. And this is one plane ablation. After one plane ablation, we tried to find another plane and continued ablation to cover most of the tumor. Left side is before treatment and the right side is 1 month after treatment. We can see necrotic area in the tumor. In our study, we included 10 patients, 7 NET, 2 SPN, and 1 insulinoma. When we analyze our treatment outcome, 70% of the patients showed complete resolution. And 2 cases showed minor complications, such as abdominal pain or pancreatitis. So at the current moment, indications of EUS-guided RFA can be neuroendocrine tumor, SPN, or pancreatic cancer, and adrenal tumor. EUS-guided RFA can also be applied for the palliation of pancreatic cancer. This is one of the cases. Our group is conducting the clinical trial of combined chemotherapy and RFA for pancreatic cancer patients. Here we can see large tumor mass in the head of the pancreas. For the treatment of this tumor, we did EUS-guided RFA several sessions to cover this large hypoechoic mass. And on the day of RFA, we also combined the chemotherapy. After several sessions of EUS-guided RFA combined chemotherapy, now we can clearly see marked size decrease of this original tumor. If you look at the reviews on EUS-guided RFA, we can realize there are many groups investigating EUS-guided RFA actively, showing variable results. There are potential complications after EUS-guided RFA: pancreatitis, MPD stricture, perforation, and bleeding. When we are trying RFA for pancreatic tumor, we should remember that the pancreas is very close to many vital organs. Lastly, for the management of pancreatic cystic tumor, we can use ethanol injection technique or ethanol lavage. If there is any growing cystic tumor in the pancreas, we can use EUS for the delineation of the lesion. This is cystic tumor. Now, linear EUS scope is going into the stomach, and we can delineate the lesion. And we can puncture the cyst and aspirate the cystic fluid. And then pure ethanol can be injected into the cystic cavity. So aspiration and the injection of ethanol can be repeated 3 or 4 times. And then finally, we can instillate a small amount of paclitaxel into the cystic cavity. This technique is called EUS-guided ethanol lavage or cyst ablation. The ideal indications of cyst ablations are unilocular or oligolocular cystic tumor, size ranging from 2 to 6 cm, and without malignancy and without clear MPD communication. When we treated this large MCN after two sessions, we can see complete resolution in 7 years' time. We analyzed our long-term outcome data after EUS-guided cyst ablation and reported the result in endoscopy 2017. Among 164 included patients, 158 patients received long-term follow-up. The mean follow-up was more than 5 years, and some of the patients received follow-up more than 10 years. When we look at the treatment response, complete resolution was observed in about 72% of the patients, and the partial resolution in about 20% of the patients, and the persistent cysts in about 8% of the patients. Some may argue the long-term durability of this type of therapy. So we analyzed the long-term recurrence rate. Once CR is achieved, even after 10-year follow-up, the recurrence rate was just 1.7%. So it is quite durable type of therapy. There are several groups actively investigating the technique ethanol injection for cystic tumors. I think this method can be used wisely in the near future. In conclusion, at the current moment, EUS-guided tumor therapy is actively investigated for the management of cystic tumors and the solid tumors of the pancreas. In the future, early diagnosis followed by EUS-guided tumor therapy can be the mainstay of therapy instead of sending patients just for surgery. Thank you very much for your kind attention.